guys, welcome back. Mama Dr. Jones, OBGYN, and Mom to 4. Today we're going through an episode of The Good Doctor, which is relevant to pregnancy and gynecology. I've never seen an episode of the show, and every time I do that and tell you that, you guys just roast me in the comments because I don't know what's going on and tell me how great the show is and that I should watch it. But what you don't know is that I can't do that and also still make these videos for you because I don't have time to do both. I'm being here for you. So like and subscribe because you make me do this. I'm kidding, of course. I do these videos because they're amazing and I have so much fun doing them and you guys seem to learn a lot from them and it's great. What's not great is how YouTube likes to suddenly demonetize my videos. Gynecology is scary. Advertiser unfriendly. Don't talk about the V word or the SEX word. Totally evidence-based science educational for people to know about their bodies, but they don't like that on the internet. But I have news for YouTube, you guys like it. So it's only a pain for me because when they do that, the videos don't make money, which is, you know, one thing, but they get suppressed in the algorithm, meaning way less people who need the information get it. This is season 2, episode 11 of The Good Doctor. If you haven't seen it, please don't watch this. There will be spoilers. I don't want to hear about it in the comments, making it very clear to you, okay?
Pregnant woman a mask?
Kelly, can you hear me?
It's empty.
Kelly!
Dr. Resnick.
They are quarantined for some communicable disease that is causing people to die. It's very reminiscent of when I was a resident and the Ebola outbreak was occurring and we had to go through like, what will we do if there are pregnant people or GYN patients in the hospital who are infected with Ebola? It was a whole planning process as we all struggled to get information on whether this was going to actually be a major outbreak in the United States or not. It was very scary and very serious, and I remember it feeling like in my head, if it actually came to fruition, that it would look something like they're just depicting here.
ST depressions have improved and Viola's water broke.
What? When?
It appears quite recently. Given you're only 36 weeks gestationally and there's no sign of infection, the baby should be able to stay in utero for at least 24 hours.
It appears we have a pregnant patient who is 36 weeks and her water broke. Usually, when your water breaks, within 24 hours, you will go into labor. The likelihood of her staying pregnant another 24 hours, if she's already having some contractions, which it's a little hard to tell, and if her water's broken at 36 weeks, is probably pretty low. Sometimes if someone's water breaks really early, 24 weeks, we can keep them pregnant for weeks and weeks. It really just depends on the situation. We don't always know what causes someone's water to break early. It appears they're monitoring the baby. There's nothing going on right now, so what I think they're probably going to do is just watch and wait.
Based on past national quarantine mortality rates, we have a very good statistical chance of surviving.
You always talk like that.
Like what?
Just say whatever you're thinking when you're thinking it.
Yes, it's good to be honest.
They have 2 monitors on her abdomen. One is a tachometer, which is monitoring for contractions, and the other is a monitor for the baby's heart rate. And in the brief second that you could see the contraction and baby's heart rate on their monitoring, the baby's heart rate was very happy looking. It was exactly what we look for. Good variability, normal baseline, big pretty accelerations.
Viola's BP is 180/100. She may have preeclampsia and an oncoming seizure. We need to induce labor.
No, he's not being born in here. We are waiting for quarantine to end.
Placenta isn't getting enough blood flow.
So we need to get him out. This is going to be your first baby. And mine.
Whoa. Okay. I have a little bit to say about that. What he essentially said in normal terms is, your baby's heart rate still looks great. You've had one blood pressure that is higher than it should be, concerningly high. In the real world, I would say we should treat it, but he's treating it like, oh my gosh, emergency, we need to deliver your baby right this second, you're going to have a seizure. He's done no other evaluation of the patient, and that is absolutely not appropriate care of this patient. If I had a patient who was otherwise fine and her water had broken and the baby looked great on the monitor and she had no other symptoms except for a single elevated blood pressure, I would give her blood pressure medicine. We would do some labs, I would check for protein in the urine, and under normal, easy circumstances, sure, inducing and having a baby makes sense. But in dire circumstances like this, where they're trying to not deliver, if her blood pressure came down and was perfectly fine and everything looked good, then it wouldn't be unreasonable to just give this more time and see if they could get to a point where it was safer to deliver her baby. There's very few situations in the real world where I would think somebody had blood pressures that high and their water was already broken at 36 weeks and we should not induce them. Across the board, the right medical management, but the urgency in what he's doing and saying is absolutely not warranted.
That's very loud.
Any crowning, Dr. Murphy?
No, she's dilated at 6 centimeters and I don't feel the head.
I mean, the obvious. His bedside manner is terrible. I cannot imagine treating somebody like that.
In 7 hours since her water broke, the baby's stuck. Use Leopold's maneuvers to identify the location of the baby.
Fetus is transverse. He's lying roughly 30 degrees to the left side. We can't deliver the baby.
I thought this show was going to be way more accurate than this. I am just, like, shocked. Thrive Market is the sponsor of this video. They support health and education. That's why they support me. I've used their service for a couple of months now, and I'm really, really happy with it. They are on a mission to make healthy eating more accessible to everyone. Why is that box so big? I'm about to tell you. They have diapers and big giant bags of coffee. If you'd like to try out Thrive Market and support the channel in the process, because they support me in giving you this information, which is really, really awesome at a time when YouTube is making me insane with that. They are offering you guys 25% off your first order and a free month-long membership. You go through their website, you can sort it by a bunch of different diets, animal-friendly beauty products, or keto, or whatever it is. They have all kinds of different designations. They have lots of things that I can't get at my grocery store here. Order at least one box and see what you think. Support the channel. You're awesome, and I appreciate you. They say do Leopold's maneuver. He just laid his hands on her really quick while she was contracting and decided the position of the baby. You can't feel through a contracted uterus to identify the fetal position. Oh, the baby is transverse and it's 30 degrees to the left. Not how it works. Leopold's maneuver are very distinct, different ways that you feel of the baby to get an idea of the position. And it's not something where you just stick your hands on and go, yep, that's the position.
What? Why not?
We need to turn the baby. We need to do an external cephalic version.
Or a C-section. I have assisted on several.
In operating rooms with an experienced attendant, we are not doing a C-section here. Tilt her bed. I'll grab the gel.
They're talking about doing an external cephalic version. The cervix is open enough that the umbilical cord could easily fall out. So I'm really worried if they choose to do that. We would not probably ever do that in real life just because of the high risk of cord prolapse at 6 centimeters with your water broken. If you put yourself in this situation where you're in this dire situation, you don't have somebody who's definitely capable of doing a C-section, you don't have access to operating rooms with all the equipment that you need, you're quarantined. I don't think not trying the version is definitely what I would do. It's hard to say since I've never been in that situation, and I hope that I never am.
Dr. Murphy?
Yes, I can feel the head. We need to rotate in the same direction. Deep breaths, Viola.
I can't do this.
Squeeze my arm hard as you can.
The fetus is moving.
The depiction that they did there was relatively accurate. The baby's heart rate was still up on the monitor the whole time. You can't get good movement on the fetus from the outside if you leave those belts on tracing the heart rate. So we do want to keep track of the heart rate when we're doing a version, but we generally do that by trying to move baby and then having someone look with the ultrasound, make sure the baby is tolerating the movement well. I guess I should explain what an external cephalic version is. It's a procedure that I do clinically, and it's something that we can offer to patients. In the real world, generally, if a patient has a baby that is breech or transverse and they are 37 weeks pregnant and would like to try to turn the baby to allow for vaginal delivery rather than to plan for a C-section, we would try to do that before they're in labor and before their water breaks, because that increases the chances that it would work and decreases the risks that come along with it. You palpate on the belly and you identify where is the head and where is the bottom, and you try to get the baby to roll and turn to a ideally head down position. Although in this situation, honestly, would probably try to get the baby in whatever position it was most easily going to rotate without having the umbilical cord fall out.
Head is facing the cervix. One more push. We just need to... Stop! Placental abruption. Baby's heart rate is decelerating. Please page an ObGyn to supervise my first solo surgery.
Equal parts terrified and horrified right now. Abruption, making the placenta come off the side wall of the uterus, is a complication that can occur with hypertensive or high blood pressure problems in pregnancy, and it is a known risk of an external cephalic version. It's very rare with an external cephalic version, but it can happen.
Will be supervising me for the C-section. She's the director of obstetrics and gynecology here. I'm sure she's much more qualified than your personal ObGyn.
Relax, you're gonna be fine. What's the status?
Nerve block is in, and I gave her a liter bolus of saline.
I am shook. I don't know if I can watch this.
Throw some chloroprep down and make a 5-centimeter fan and steel incision.
Apparently, she's going to supervise from the outside. They're still going to wear gowns that are not appropriate gowns for operating rooms, but also they're not in an operating room, so now I'm beginning to think that maybe they just don't have access to operating rooms. Somehow, however, they did find an anesthesiologist or somebody capable of placing a spinal block in, so she's going to be awake for the surgery. That's exciting. If I had someone operating on me who had no idea what they were doing, I would definitely want to be awake, said no one ever. Additionally, what she just told him through the door was make a 5-centimeter fan and steel incision. 5 centimeters is probably too small. Fan and steel is a type of incision that people typically refer to as bikini cut, which is used most commonly for C-sections in the US. I would like to see what kind of magician work he's about to do if that baby at 36 weeks is coming out of a 5-centimeter incision.
Abdomen is open. Retraction. Suction.
Baby's BPM is 110 and dropping.
What's happening? Dr. Murphy, do you see the uterine wall?
Blood pressure is dropping.
Dr. Murphy, the uterine wall.
Okay, 1 minute. I gotta go back and see what they said about that BPM. Are they talking about mom or baby?
Baby's BPM is 110 and dropping.
Okay, so that was baby's BPM is 110 and dropping, which makes sense. Beats per minute. The baby's heart rate is 110 beats per minute and dropping. That would be going in the direction we don't want it to go. However, we don't monitor the fetal heart rate during surgery. There's no way to do that while doing a C-section and keeping the abdomen sterile.
Dr. Murphy?
You need to make a gradual, shallow incision and cut through it. You do not want to nick the baby.
What's happening?
BPM is 95.
Okay, BPM is 95. She's got to be talking about the baby's heart rate. That's 95 beats per minute, which, by the way, is not an emergent heart rate. That's something you need to do something about, but that's not a life or death heart rate yet. Again, we wouldn't be monitoring the fetal heart rate during surgery. It's not a thing. The OB who is watching says you want to make gradual, shallow cuts through the uterus and be careful not to nick the baby. Absolutely true. That's how incisions are done. If you're just thinking about it, it would be really hard to cut a baby during a C-section, but it's not. The differentiation between a really, really thin lower uterine segment and where that stops and baby starts with the way that scalpels are made and the way that incisions are made can sometimes be really, really difficult to identify. Even with the best of ObGyn surgeons, there are still some times where that happens as a complication of a C-section, and usually it's not that bad. If it happens, usually it's not even something that needs to have a stitch or glue or anything, and in more significant cases it may need a stitch or glue. It's not always because someone's not doing a good job. It is a complication that can happen. In fact, Milo during his emergency C-section had a very tiny cut from the scalpel. I definitely see how it happens.
Dr. Murphy, please.
Dr. Murphy, should we turn up her
Dr. Murphy, you
oxygen?
need to make the cut.
Dr. Murphy, Dr. Murphy.
Okay.
Dr. Murphy.
Dr. Murphy. Okay.
No! Quiet! Everyone quiet! I need to concentrate!
Okay, I have chills I cannot imagine how terrifying it would be to give birth in a situation like this, knowing the person doing it really didn't know what they were doing and watching them get information from somebody through a door. Horrible. As the surgeon, obviously he wouldn't do this if he had a choice, and that must be incredibly terrifying. And I really feel for how stressed he seems, because that is very scary. It's scary the first time you do it in general, even if you're fully trained and prepared for that and have 3 people around you who know exactly what they're doing. But I can't imagine in that situation.
You can see the head.
Is my baby okay?
He's not breathing. We need to start CPR now.
Get a pediatric ambu bag and start 2-finger chest compressions.
He said, I can see the head. You can't see the head. When you get in through the uterus, there's a ton of bleeding. You're doing everything by feel. The baby came out and he said, it's not breathing. We need to do compressions. And she told him how to do that. And that's not how you decide to do chest compressions on a baby. And you don't start chest compressions unless the baby's heart rate is low, in addition to it not breathing. I already feel what he's about to have to do, making a decision between mom and baby. And I do want to throw in here that in the real world, that's just not something that practically happens. I mean, you would be hard pressed to be in a situation where the only person in the room who had experience with both of those problems actually had to make that decision.
There's something wrong with Viola. She's hypotensive and tachycardic.
She's bleeding out.
What we've run into here is something that doesn't really happen in modern medicine in developed countries. If you have a baby and the baby needs to be coded or resuscitated, there are other people in the room besides the surgeon doing the surgery who take care of the baby. I am never the one in charge of taking care of the baby. What I'm assuming he's about to have to do is decide between resuscitating the baby and stopping mom's bleeding. He is the only one with surgical experience. He needs to take care of mom and stop the bleeding. The person helping him with the surgery needs to work on helping the baby.
Dr. Murphy, the rules of medical priority are clear. Focus on saving the mother. Dr. Murphy, you need to stop now.
Dr. Murphy? Dr. Murphy?
I hope I never am alive when the apocalypse is happening.
We can save them both. Get me a liter of saline, a plastic bag, some surgical tape, and acrylic gauze, please. Who knows CPR? Who knows CPR?
In health,
Come with me.
Okay, horrific. He turned around and walked away from the patient who was bleeding. As we've talked about in a couple of these other videos, blood loss from an open uterine incision can be up to 500 milliliters per minute. That's the blood flow through the uterine arteries. And so she could already have lost her entire blood supply and be dead by the time he walks to the waiting room and be back.
2 fingers right here in the middle of his chest. Press down twice per second. Every 15 seconds, stop and squeeze the bag.
Twice.
Don't press too hard or you'll crush his heart.
He said, don't press too hard or you'll crush his heart. That's the point of chest compressions, is to compress the heart. More commonly, people don't press hard enough with chest compressions, even when doing chest compressions on a newborn.
You're making a Buckley tamponade balloon for Viola's bleed?
Yes.
What is that supposed to do?
It will control the bleeding by applying pressure from the inside.
Okay, so what they're describing is a Buckley balloon, which is a tamponade for a uterine atony, which is postpartum hemorrhage that is caused by the uterus not contracting. That's not the first step to treating what she has going on. He hasn't even closed the uterine incision yet, and that is a large majority of where blood loss comes from after you do a C-section and deliver the baby. The first thing he needs to do is look at the patient and see what is bleeding. Look at the incision, close the incision on the uterus, not the skin incision. Make sure that there's not bleeding that's happening at the uterine arteries, or that the incision you made to get the baby out doesn't have a big extension into big blood vessels. A Buckley balloon, which is a tamponade to stop bleeding, so like putting pressure on the uterus if it won't contract down, is not going to quickly stop bleeding, and it's only going to help if the uterus being relaxed is the only problem. That's not the first thing you do, ever. I applaud his thinking outside the box to make whatever that Buckley balloon thing was. I probably would have gone with uterine packing first, but hey, I like to DIY, just not in the operating room.
It's not working. She's still bleeding.
Keep injecting saline.
It gives us a little information on how she's doing. Her heart rate is 122. That is high, but it's not that high for someone who's pregnant. And her oxygen saturation is 94%. She's at least getting enough blood flow to oxygenate. However, her blood pressure is 60/20. This is bad. In a young, healthy person who has recently been pregnant and recently had extremely high blood pressure, which prompted them to want to deliver, that is an accurate depiction of how fast something can go wrong and someone can get life-threateningly ill in a situation like a C-section or a vaginal delivery. It can really happen that fast.
Vitals already over 60. Heart rate's 110.
Stop CPR. I need to see if he can breathe on his own.
You guys, I had so much hope for this show, but it's so wrong. If her blood pressure got up to whatever that was on the last one, he's not just done with her. Her blood pressure might have come up a little bit, but she lost blood. Stopping the bleeding isn't going to resolve the blood pressure problems. It will certainly help it from getting worse, but she's still gonna die if he just turns around and leaves her.
The baby has meconium aspiration. Suction catheter.
Is that bad?
Fecal matter's settled in his lungs. It's blocking his airway.
Did I do something wrong?
You most likely dislodged some of it. Without that, he would have suffocated by now.
Clearing his airway.
I like what the OBGYN in the hallway did right there. Rather than saying, no, it wasn't you, or it's fine, let them do their job, or just passing over his concern, she said, no, you didn't cause it, you might have helped it, it's fine. Immediately absolve that guilt that you know doesn't belong there and move forward. Don't hesitate, don't play with it, just go. But also, don't ignore it, because that's how guilt starts to fester and people start to blame themselves for things that they had absolutely no hand in and absolutely no control over. Meconium aspiration is when the baby has a bowel movement before it's born and then breathes in some of that meconium or poop before it's born or at the time of delivery. And because it's really thick, it can be really thick. It's not always really thick. It can get stuck in the alveoli of the lungs and not allow them to fill with air and transfer oxygen. So the baby is having trouble breathing. What they're saying is because it has aspirated or breathed in meconium. We see meconium a lot. So I want to add this in because there's probably some of you watching this who've either had a baby with that or will eventually have a baby with that. It's pretty common, and most of the time it does not cause life-threatening problems. It should absolutely mean that a pediatric team member is available to suction the baby's lungs out at the time of delivery if needed, but it shouldn't be panic-inducing. Give the lady her crying baby a miraculous recovery and you're just holding it like Simba, taking all the credit. I mean, yeah, great job. I'm very proud of you, but give the lady her baby.
He is okay.
That mom's just been through absolute hell. Give that baby to her.
Christmas miracle.
When did he close the incision? How is she so fine after losing that much blood and almost coding? The baby just like perked up immediately with a little bit of suction and no other intervention. Not realistic. Really interesting episode. I expected it honestly to be a lot more accurate based on the reviews of the show, so I'm super disappointed that they've missed the boat on the OB side. So hey, good doctor, if you need a consultant who knows about obstetrics and gynecology, call me. I'll consult for you. I won't even charge you. Just give me some credit. I'll be happy to do it, just to make it more accurate so that we're not spreading bad information. Thank you guys for being here. I hope you enjoyed this episode. If you want to support this channel through Thrive Market, I would sign up for the free month membership and make your first order and see if you like it. Be kind to yourself, to each other, to me. In the comments, be kind, and I will see you next time.